Audio recording for this meeting has begun.
Good afternoon. Thank you so much for being here today. My name is Susan Collins, and I'll be co-presenting today about harm reduction treatment, meeting people where they're at, with Lonnie Nelson. So welcome. Just to give you a quick idea of what our session will look like today, we'll start off with some introductions so you understand also the context in which this work was developed. We'll talk a little bit about substance use treatment engagement among American Indians and Alaska Natives, and provide a definition both of the overarching concept of harm reduction as well as the much more specific harm reduction treatment. And finally, Lonnie will close by talking about some means that we have been working on to adapt harm reduction treatment for Native populations. So first of all, a little bit about myself. Again, my name is Susan Collins. I'm a licensed clinical psychologist and associate professor at the University of Washington Harborview Medical Center, where I co-direct together with my partner in science, Seema Cliffosephi, the Harm Reduction Research and Treatment Center. And you can see our staff down at the bottom there. And I, of course, had to also feature a picture of my family, including my partner in life and in science, Lonnie Nelson. And I also really want to acknowledge a really important part of our work at the Harm Reduction Research and Treatment Center, our Community Advisory Board members at 1811 Eastlake, which is a harm reduction housing first program in Seattle. In that particular housing project, about a third of the residents are Native, and these individuals, through the Community Advisory Board, have very strongly helped to shape the work that we're talking about today. I want to especially acknowledge Lavella Black Bear, Jimmy Rosario, and Sean Buffalo Meat for their contributions. And as a European American, I also think it's important to acknowledge that I'm standing on Coast Salish land and acknowledge that if it were a just world, I would not be here today, where white Americans and Europeans committed many atrocities and continue to against the land and Native people. So with that acknowledgement, it's with much gratitude and humility that I accepted the invitation to come today and to share with you what we've co-learned from and co-developed with communities we work with here in Seattle. And Lonnie, maybe if you could introduce yourself.
Yeah, sure. My name is Lonnie Nelson. I'm a clinical psychologist and I'm Eastern Band Cherokee. The Eastern Band are the Cherokee who resisted relocation, and my family in particular headed slightly north of their ancestral lands to the border between Tennessee and Virginia, a little place called Rose Hill, and that's where my grandma was born. Growing up, I moved around quite a bit. My mother was an IHS nurse, so I got to live on several different reservations. I graduated from high school in Tuba City High there in Tuba, Arizona on Dene lands. And after a freshman year at Northern Arizona University as a chemistry major, I had a change of mind and heart and moved down to Tucson, attended Pima Community College while I decided what I wanted to do with myself. And then after a couple of years there, transferred to the University of Arizona, where I completed my bachelor's, master's, and PhD in clinical psychology. I'm currently working at an organization called Partnerships for Native Health at Washington State University, where we focus on health disparities in Native communities. And because my work is population-focused as opposed to disease-focused, I end up working with experts in a lot of different fields. I'm currently principal investigator on studies ranging from suicide prevention interventions to stroke risk reduction, talking circle intervention, to smoking cessation intervention using text messaging, a lot of different areas. But what I try to do is focus on finding evidence-based practices that address problems that communities are concerned with and then culturally adapt those interventions so that they work and fit in that community. And yeah, I end up working with experts in a lot of different fields, and I was so fortunate to have met Susan when we came together to work on substance use disorder treatment. Full disclosure, Susan and I are married, and we have a beautiful daughter named Amelia Elizabeth. Amelia after my great-grandmother, and Elizabeth after her grandmother. So other than that, we don't have any conflicts of interest to declare. So I'm going to talk a little bit about why harm reduction might potentially be a good fit for Native communities facing substance use disorders as a problem in their communities. First off, just summarizing some of the work by SAMHSA and their National Survey on Drug Use and Health in 2015, they found that 7.9% of the respondents who were Native in that survey would benefit from treatment for illicit drug use. However, 94% of these respondents, of that 7.9% of respondents, did not receive treatment. Now, of those who needed treatment but did not receive it, the vast majority felt like they did not need treatment, 97%, as you can see over here. There's just a teeny little sliver that felt they needed treatment and did not make an effort to get it, but the rest just felt that it wouldn't be helpful for them. They didn't need it. That's in the context of the fact that nearly all available publicly funded treatments for substance use disorders focus on achieving and maintaining abstinence from substances. This is reinforced by state laws that govern how things are reimbursed, and is often recommended as best practice because people equate substance use with trouble. However, qualitative studies have shown that Natives in particular are not always interested in abstinence-based goals, and they perceive existing abstinence-based treatments like 12 steps in cognitive behavioral therapy as mismatched to their cultural values. So you might ask yourself, well, what cultural values are we talking about? So fortunately for us who need to answer that question, the Society of Indian Psychologists, who are a leadership body within the American Psychological Association and who comprise an entire division within the APA, wrote a commentary on the APA's ethical guidance and ethical principles that was based on the difference in worldview from indigenous perspectives from that of the white European perspective that the ethical principles had been written. And at the outset of that document, they identified a set of 14, actually, from which we've just kind of taken distilled down the big themes from that into 6 main pieces. That while there is a diversity of cultural practices, beliefs, traditions, origin stories, and so on from the different tribes, of which there are 567 federally recognized and an additional some number of state recognized tribes, there's definitely diversity of belief and values there, but there are also some commonalities, and that's what the Society of Indian Psychologists values statement at the outset of their commentary on the APA ethical principles really pulled together and wanted to point out to the reader so that they would have that context as they went into the commentary. And if we think about how these cultural values might apply to the therapeutic relationship and one's approach to treatment of substance use disorders, you think about this first principle of balance and harmony and how that might apply, could be taking the stance that what you really are looking to do would be to help the person achieve a sense of balance and harmony within their life, whether they're using substances or not. And to approach that relationship with a sense of respect and reciprocity, understanding that you're co-equal partners in this therapeutic relationship with the client sitting across from you. And that, of course, inherently recognizes this connectedness between the two of you, but also this therapeutic relationship should take into account the connectedness between the individual and their community, the individual with their history, the individual with their environment, and understand that context is where all of this interaction is taking place. And to do that in a spirit of collaboration and partnership with your client, working with them as a whole person and understanding their relationships, not only to their substance use, but also to their families, to their communities, to their tribe, to their environment, to their past, their future, and how all of that is interwoven with their present situation. Also, it's pointed out by the Society of Indian Psychologists value statement that indigenous perspectives have a community orientation, and that is to say that the autonomy of the individual is really only valuable in the extent to which it relates to their contribution to their community and those that they are connected to. And these are cultural values that we can carry into our approach to treating individuals who are experiencing substance use disorders. And I think that goes a long way toward making the way that we approach this treatment culturally congruent for Native populations. I'm going to have Susan describe what's going on here because she actually conducted this work.
So a few years ago, my colleague Seema and I did some research. We were asking, I believe in the end, it was 50 people with a lived experience of homelessness and alcohol use disorder, a large proportion of whom were Native. You know, what kinds of things they wanted to see happen in their lives and how they could redefine treatment in their own vision. And, you know, we really went in with kind of assuming there were going to be a lot of deficits we'd have to address because that's kind of, you know, when you think about Western treatment, that's oftentimes the focus and the concentration. What we came out of that research with was a much greater understanding of people's strengths, and that's what we really try and do. We try and center that and amplify that in harm reduction is really helping people come back to themselves and see their strengths and capitalize on their strengths so that they can really participate in their own healing and move forward on their own pathway to healing.
Okay, so in talking a little bit about what harm reduction is, it's a grassroots, user-driven set of compassionate and pragmatic approaches to reducing the substance-related harm and improving quality of life without requiring abstinence or even use reduction. So that's what's depicted here in the little diagram. So the philosophy of harm reduction is compassionate in the sense that the practitioner attempts to feel with the client, but in a way that seeks or hopes to reduce their suffering and harm. They recognize that substance use has pros and cons. You know, people get something out of their substance use, and they wouldn't do it if they didn't. And recognize that substance use is here to stay. It's not something that's likely to become eradicated like polio. There's no vaccination for substance use. And that it's complex. It exists within a social context and a familial context and a personal history. But that said, it is not the sum of the client. The client is greater than their substance use. They as a whole are much more than simply the disorder. And the approach to treatment from a harm reduction perspective is pragmatic. It is not use reduction. It is focused on quality of life as opposed to reduction in use. It is client-driven. All of the goals are client-driven. The way the relationship is navigated is client-driven to a large extent. Advocacy for social justice and racial equity are just part of what we are striving for by engaging in what we're doing.
And just to chime in, that's because we acknowledge that people of color and other marginalized communities, like people from lower socioeconomic backgrounds, are disproportionately impacted by the substance-related harms, both their own and secondary harms that happen in their communities. And so acknowledging that and acknowledging that substance use isn't just a behavior but exists in this larger social context and that we need to advocate to support people in that context is really important.
Yeah, definitely. And lastly, one of the most pragmatic features, I think, of harm reduction treatment is that we're open to any positive change that the person makes, and any positive change is considered a step toward health. So harm reduction can be practiced at various levels. At the policy level, this may include decriminalization of substances and a focus on rehabilitation as opposed to punishment in the justice system. At the population level, you have examples of like public service announcements like friends don't let friends drive drunk kinds of campaigns. At the community level, you might have safer injection sites where people are less likely to overdose under the supervision of a healthcare professional. And that's of benefit to the community of users and also to the community in which they are using, because you're less likely to have broken hypodermic needles on the sidewalk where little kids might stumble across them. What we're going to be focusing on today is really down at the person level. And this is where most clinicians interact with patients and clients. It's really at the level of the individual where harm reduction treatment is focused, noting that we can engage in harm reduction activities at all of those levels. So distilling the philosophy and approach to harm reduction, we were able to distill down to a core set of harm reduction values. And these are a focus on quality of life as being the real goal for treatment, regardless of substance use, on the principle of co-learning with the client about what's going to work best for them and how their path forward to a healthier self looks. And we're just discovering that right alongside them. It's grounded in ecological systems theory and takes into account the context in which the substance use is occurring and in which the person is functioning at the geopolitical and social and societal and biological levels, all of this. Focuses on collaboration and working in partnership with the client as opposed to in a more directive relationship as you might find in cognitive behavioral therapy or even in motivational interviewing. Recognizes that people are greater than their substance abuse or substance use. There's more to it. There's more to them than just their habit. And it's a grassroots movement that was co-developed with a population that it was intended to be of benefit to. And this gives us the mindset and the heart set of harm reduction. So if you try even a little bit, you'll see some pretty consistent crosswalks between the indigenous values as outlined by the Society of Indian Psychologists and the harm reduction values that guide the approach of harm reduction treatment for substance use disorders. It really doesn't take a rocket scientist to see the parallels there. So I'm going to hand it over to Susan here, and she's going to talk a little bit about what really constitutes harm reduction treatment.
So as Lonnie mentioned before today, because many of you are clinicians, we're going to focus the training most at the individual level, while understanding as harm reductionists, we care about and also want to be active on the other levels, but this might be our day job, so to speak. So the individual level, the focus is really on how we talk to people. And that brings us to harm reduction treatment more specifically, which is part of this larger umbrella of approaches that fit into the rubric of harm reduction. So when we talk about what harm reduction treatment is, we also like to talk about what it is not. So harm reduction treatment is not any of these specific therapy approaches. And that is not to say that there's anything wrong with these approaches. In fact, they're evidence-based and they can be very effective. But they're very effective for that very small percentage, I believe Lonnie said it was about 7% of American Indians and Alaska Natives who need treatment and get it. But for that other 94%, these kinds of abstinence-based treatment modalities, more directive treatment modalities, are just not reaching the people that we need to be serving. And so a lot of times people ask, well, but why, what differentiates harm reduction from abstinence-based treatments like these? And really the key piece is that these other modalities really rely on and have as their foundation provider-driven goals. Some people challenge that and think, well, motivational interviewing, though, that's patient-centered. And I would say it is definitely patient-centered, and many treatments, many effective treatments are patient-centered. I would go one step further with harm reduction and say it's patient-driven, that the patients really drive the agenda and the goal setting and the content of those goals. And in terms of motivational interviewing, it is certainly a kinder, gentler way of talking to people, and I highly recommend talking to people in a motivational interviewing style most of the time. It makes relationships much stronger. But it is a kinder, gentler way to talking to a person about moving in the direction of provider-driven goals or abstinence, as is typically the case in substance use treatment. And Bill Miller says as much in their third edition of Motivational Interviewing. Chapter 10 is called When Goals Differ. And he indicates that many people in the existential or more humanistic psychotherapies, the less directive psychotherapies, and you can include harm reduction in that group, would disagree with the fundamentally directive style of motivational interviewing wherein treatment providers decide on the optimal goals for patients. And so that would be the fundamental difference, as really focus on patient-driven versus provider-driven goals. And just to reiterate something Lonnie said really clearly before, harm reduction is not the same as use reduction. We want to be really clear, though. Use reduction can be one mean to the end of harm reduction, right? So people can choose to moderate their use, engage in lower amounts of use, or even so far as to become abstinent. But harm reduction is the true end when we're talking about harm reduction treatment. So abstinence is viewed more as a pathway to harm reduction and one of many pathways to harm reduction. And just to start to introduce some of the harm reduction treatment components, basically as you are engaging these components, you're really engaging this harm reduction mindset and heart set that we focused on in the first part of this talk. So really thinking about compassion and pragmatism, doing whatever it takes to reach clients, engaging in advocacy on their behalf, helping them to engage in self-advocacy as human beings versus just as substance users. And within that, we have concrete counseling components that we use, and we'll be talking about that today, multidimensional assessment and feedback, and then having clients lead which outcomes are most important for them to track over time to understand the success of our treatment. We also discuss safer use strategies and the relative risks of different ways of using substances. And we elicit and then ongoing check progress on participant-driven harm reduction goals. And these days, I think harm reduction treatment is going to be a really great adjunct to what we're doing in even medicalized settings, right? Because these days we have really great supports for working with clients towards harm reduction. Things like, in thinking about opioid use disorder, naloxone or Narcan, the opioid rescue drug that reverses overdoses. Things like opioid substitution therapy, methadone and Suboxone. These are not things that are meant to achieve abstinence from opioids. They're meant to, for example, keep a person alive one more day so that they can make more healthy and safer choices for themselves and their families. Or it is giving the person the actual substance that they are addicted to help them maintain on a lower dose and increase their quality of life. So in fact, these medications these days are really striving towards harm reduction, but in the past, we as providers haven't had ways of talking to patients in a way that's congruent with the harm reduction that our medications are actually achieving. And that's what we're trying to do with harm reduction treatment. And what we find is that what we found in our first trial, our first randomized controlled trial of harm reduction treatment that we'll be reviewing today, we found a 71% reduction in alcohol-related harm when people experienced harm reduction treatment versus services as usual. 66% reduction in peak alcohol consumption, 63% reduction in people's experience of alcohol use disorder symptoms, and even though we weren't going for abstinence, again, this is a harm reduction approach, we found a 16% reduction in positive urine tests. So that exactly illustrates what we were talking about before, that abstinence is one pathway to achieving harm reduction, and it is one that even when you're doing harm reduction treatment ends up becoming participants' preferred goals in some cases. So harm reduction doesn't preclude or negate abstinence or abstinence-based goals. It just doesn't mean that you only can have abstinence-based goals. We want to talk a little bit, since everyone on this in this particular training is a clinician, we want to talk a little bit about how to put harm reduction treatment into practice. So reviewing the mindset, the heart set, and concrete tools within a therapeutic context. And first of all, the mindset. So I know we've kind of talked about how harm reduction is not use reduction. We want to kind of translate that to the therapeutic context specifically, right? So in use reduction modality or an abstinence-based substance use treatment, the ultimate goal is already preordained. It's abstinence. And that's based on the belief that use and problems, like the level of use and the level of problems people experience, are in one-to-one agreement. We've thought that for many years, but a few years ago for National Institute on Alcohol Abuse and Alcoholism, I conducted a worldwide review of the literature. And what I found was really shocking to me and wasn't what I was expecting. It was that when we look at people's experience of alcohol-related problems or alcohol-related harm, and we look at socioeconomic status, and we look at other social factors, it turns out that people in the world who belong to the dominant culture in this particular country, that would be white males from a higher SES, we found that they can consume an awful lot of alcohol and experience relatively few alcohol-related problems, whereas people of color or people from lower socioeconomic statuses, people from marginalized communities like homeless communities, were experiencing disproportionate levels of alcohol-related harm for the same levels of use or even lower use. And so we now know that this idea that use and problems just exist in one-to-one agreement, and if a person stops using, their problems will go away. We now know that that's just not true based on a lot of different social factors. Within the use reduction perspective, though, the goals are prescribed by the provider. They basically prescribe the treatment pathway, the pathway to recovery, as well as the goal, which is abstinence. And in this perspective, the doctor knows best. And the far less directive harm reduction perspective, the goal, again, is harm reduction versus use reduction. And again, the risk of the problems is now we've adjusted our understanding of this ratio of problems and use. We now know that the risk of problems is variable and individually based, and really there's a lot of social factors involved in it. Our role is more a predictive one. We're kind of like a meteorologist. We help clients to sort of assess the potential for harm based on their current behaviors in the same way a meteorologist would predict a thunderstorm. We help them assess just the relative risks of different substance use behaviors and then step away so that and respect their autonomy to make their own decisions about what's going to be a safer and healthier choice for themselves, their families, and their communities. And in this perspective, the client knows better. So that's how we translate the mindset to a harm reduction perspective, and in doing so, you can reflect this mindset. It's really important to introduce this in like the rationale when you first start treatment with someone so that people are really clear on what the harm reduction perspective is. It might be a new perspective for them, and it will probably, after they understand that, will make them a little bit more at ease with talking to you about what's really going on with them because they don't feel like they're going to have to conform to this prescribed goal of abstinence. And when we're walking with people along their pathway to recovery, I mentioned we talk about relative risks, and these are some examples of relative risk hierarchies that we review with clients. Now, these aren't things that we even necessarily show clients in terms of, like, we hand them a figure and show them these, although I have to admit the Harm Reduction Coalition has amazing self-help brochures, pamphlets, and other materials to help people learn how to use more safely. But we really drop in this information more, the psychoeducational information more discreetly and make it really conversational. And so, if a person's goal ends up being not wanting to go back to the hospital, we say, well, what are some of the things that have landed you in the hospital? And, oh, it's the abscesses. Okay, well, maybe, would you mind if I told you a little bit about how you can inject more safely? And then using this kind of information just to plug that into a conversation, and also providing them with a lot of reinforcement for things that they already are doing that keep them safer or healthier. For example, if they're shooting in their upper arm and they are, not shooting downstream, really praising them for that and say, wow, it's really great that you're already taking a lot of measures to take care of your veins and stay safer and healthier when you use. So acknowledging the good things that again, this is the strengths-based, capitalizing on the knowledge that's already there and the expertise that they have in their lives. This is a menu of options that we've recently used in our work. Right now we're working with homeless individuals who are smokers at a shelter in downtown Seattle and talking to them about safer ways to obtain nicotine, so safer nicotine products. So continue, of course, is a possibility because it is their decision to make. But if they start to reduce their smoking, that can start to reduce their smoking-related harm. And as soon as they're switching to chew tobacco, e-cigarettes and vaping, and nicotine replacement therapy, they're substantially safer in terms of the way they're taking nicotine in. Nicotine itself is although it's the part of smoking that makes it very addictive, it's actually not a harmful substance in and of itself. It's a stimulant, very akin to really strong cup of coffee, for example. So what we try and tell people is, if they move just to chewing tobacco, just a little bit, still using tobacco products, but stopping the smoking, that can reduce their harm by 85%. It decreases to 95% with e-cigarettes and vaping, and then to 99% with nicotine replacement therapy. So just having people be aware of the relative risks of their behavior. And this is an example for alcohol-related harm, and talking to people about lower risk and higher risk ways of consuming alcohol if their goal is to reduce their experience of blackouts. And that's something that they've really struggled with, because during blackouts, people experience exponentially more risk of alcohol-related harm for all kinds of different reasons. So these are things that you work into your conversation with folks. This is the mindset of harm reduction, helping people to assess their current substance use behavior to figure out how to reduce the risk and how to use more safely if they continue to use. Then we also are practicing this mindset in a hard set as well, simultaneously. So hard set is really the way that you're sitting with the person across from you. You want to, convey openness to the other and the other's values. So not assuming that your values are the same as your patients or your clients, and also appreciating that they have a value system that can be very important to them as well. You want to express compassion. I think Lonnie before defined this as a feeling with. That's the Latin roots for compassion. But it's a feeling with that just doesn't stop there. It's a desire to reduce suffering, but reducing suffering not on our terms as providers, but on an individual's terms. So really figuring out together with the person what that would take for them to reduce their suffering. Acceptance for different kinds of behavioral issues that come up when people are using substances. Acceptance for, we work with a lot of marginalized communities where they might be not in the best shape when they come in, and we accept people where they're at, and we work with them where they're at, because usually when people are in poorer health, they're less able to attend to their hygiene, they are experiencing psychiatric symptoms, that's when they need us the most as providers, or they're intoxicated. Pragmatic, we're pragmatic, so doing whatever it takes to help people and communities reduce their substance-related harm. And that has a lot to do with working with people where they're at too, doing whatever it takes. And that can be outreach, that can be phone conversations, that can be figuring out transportation to get a person to things that they need to get to in their lives. We're flexible, and I think a lot of these things we would say are a part of good patient-centered care. I think where harm reduction takes it to the next level is that we aspire to help people achieve transformative change in their lives. So we're about reducing harm and leaving behind harm to the extent that is possible for a person, but for us it's just as much about what they want to move towards and what brings meaning into their lives, and really supporting them in those endeavors as well. And then finally, advocacy. So advocating on behalf of our clients, even to our own treatment teams who may be abstinence-oriented. So modeling harm reduction and speaking positively about our clients' strengths in staffing meetings versus focusing on deficits, and really modeling acceptance and compassion for our clients. And also encouraging clients to self-advocate. And when they can't, we step in and do that for them when they're facing larger systemic issues that make it hard for them to move forward with achieving quality of life. I'll hand it over to Lonnie. Oh, no, we're going to talk about harm reduction treatment tools, right? So there are concrete tools that we practice like in the context of this heart set and mindset. And first and most important, I think, is to really assess a person's substance use in the larger context. So we do multidimensional assessment. And of course, we want to assess quantity, frequency, and substance-related harm. But we also want to look at things like Lonnie talked about before. We want to acknowledge that people use for real reasons, and these might be very important reasons for them. So we like to incorporate decisional balance to understand what people are getting out of their substance use, to help them start to think about other ways that they can achieve those positive things, or how they can continue to achieve those positive things while changing their use in a way that's more safe. We also want to talk about quality of life, and that can mean different things to different people, but we assess health-related quality of life as a matter of course, not just people's substance use outcomes. And then also looking at biomarkers. The feedback we've gotten in our clinical work and in our research is that people are really excited to learn about their health as long as they can understand what those biomarkers mean and they have context for that, and they feel like they're involved in their health care versus, that a lot of the assessment we do with folks in the office can be like a black box. People don't really know what's going on. So as long as they can be more incorporated in the process, sometimes they can really appreciate even these very medicalized kinds of outcomes. And just to give you a little bit of an idea of what some of these assessment measures look like, the SIP-AD is something that we use in our research, but also in our clinical practice, and it is 15 items that help people to think about the extent of their substance-related harm. And that is, I would say that's the most paramount measure that we really rely on in harm reduction treatment that we do at the University of Washington. In terms of health-related quality of life, this is just one example of a health-related quality of life questionnaire. This is the EuroQual 5-dimension, five-level, thank you, 5-level questionnaire. And you can see that, substance use might be affecting them in various kinds of ways. And it might be transactional. Maybe their depression is heightened by their substance use and vice versa. And so really this is about, thinking of the person as a whole and really assessing how they're doing in different ways. And then this is an example of a decisional balance. And the way we practice the decisional balance on harm reduction is we might talk about, this one, for example, is about drinking. We might ask people about essentially the pros and cons, the good things, not so good things about their alcohol use, the way they're using alcohol now. And then we ask them to come up with an alternative plan, because traditionally the decisional balance would have as its other side abstinence. So what are the pros and cons of abstinence? But we don't want to prescribe that. So we'll ask people, what would an alternative drinking plan look like for you that you feel like you would be helpful to reducing your alcohol-related harm? And then we talk about the good things and the not so good things about that, so they can really weigh their readiness to try that new behavior and really think through what are the potential outcomes for them either way. And then once we've done a lot of assessment, we do client-led tracking. And what that basically means is that the client then can choose which of these kinds of outcomes they want to focus on, what's the most important thing for them. And then we track with them how they're doing over time. Many of my clients really like to look at the SIP-AD measure, and so we'll use that measure once a month when they come in. I'll see clients, most of my clients I see weekly, and we'll use that measure once a month, and then I will enter that into a graph, and they can see what that looks like. And what that basically, I introduce that by just saying, this is the measure to help me see, I'm a harm reductionist, and you're here to for harm reduction, right? And so let's see if we're actually accomplishing that together. And they get to monitor that. And in many cases, we see, their trajectories of substance-related harm decrease, and that's really exciting, and then we really want to support that. And when we see that there are blips, we really analyze that together, and we talk about what could explain that, and what do I need to be doing differently to be more supportive as a therapist for them to be able to help them achieve their goals. So it's really like transparent QI that clients get to be involved in.
Okay, now I'll talk a little bit about harm reduction goal setting. And this is, to me, kind of the heart, no pun intended, of harm reduction treatment. What goals do clients have for themselves? We'll often ask this question in different terms for different folks. People, some, especially in marginalized communities, they have some awkwardness with the word goal. And so we might say, so what would you like to see happen for yourself as a result of the time that we spend together? And you can adapt that to, our weekly sessions, or, during your hospital stay here, whatever applies to the situation. And that wording seems to be a bit more comfortable for certain people. Yeah, this is just, I guess, going into a little more of a graphical representation of what I just explained. For our notes and our records, we'll often record whatever the client has stated as their goal for this period of time on what we refer to as the share form, so that we can keep track of the kinds of things that this person was wanting to move toward, and what kind of progress they made on those goals over the time period that we were working together. But for the client, we provide them with a document like the one that you see here, where we'll write down on the worksheet what they told us when we asked that question, and provide that to them. And during the process of determining what their goals are going to be for harm reduction treatment, oftentimes, we'll hear things like very large, long-term goals, like, I'd really like to reconnect with my daughter, who I haven't spoken to for 10 years. And so that's a really big goal, and we might need to help them break that down into smaller, more attainable in the shorter term goals. And we try and make those into what are called SMART goals. And SMART is an acronym that stands for specific, measurable, attainable, reasonable, and time-bound. These are the characteristics of goals that you can really get your head around whether or not they were achieved. And with a little bit of problem-solving help, you can usually break down those larger goals into more intermediate steps that will be required in order to get to the end long-term goal. On the back of that sheet, so this is on one side where we record what they told us when we asked them what they wanted to see happen for themselves. On the other side of that sheet, we will often have some safer use strategies. This is an example of a safer drinking tips sheet that we supply folks with on the other side of their goals statement. And really this is just a series of things that people can do to stay healthier when they drink. That's these first four up here. And then this middle area 5 here are ways to make their drinking safer itself. And then lastly, down here at the bottom are ways to change how much they drink if that's a goal that they want to pursue. And we'll discuss these with them and ask them if they've ever tried any of these things, and congratulate them on those that they have, and ask them if there's anything that catches their interest that they think they might want to use in service of achieving the goals that we've written down on the other side of the sheet. And oftentimes there are things that look as though they might be helpful in approaching those more intermediate level goals. So this is just one example. Another example, here's one that was developed for downers and depressants or opiates. And these are things like, carry rescue drugs, because naloxone saves lives. If someone overdoses and you administer naloxone or Narcan to them, they come back to life. And so maybe they'll want to use this in combination with another of these, which is, used with safe people in a safe place. So don't use by yourself. It doesn't do you much good to carry the rescue drug if you're the one overdosing and you're by yourself. There's got to be somebody around who can and will administer the rescue drug. So these are just other tips for people that are addicted to opiates and want to be healthier and safer and using in a less potentially harmful way for themselves. So lastly, the tool of checking in. So if possible, check in with clients regarding their progress toward their goals, risk reduction, or safer use. Even a brief phone call can be helpful. And that's just a way of one, assessing their progress, like Susan had showed on that graphical representation earlier, where maybe you chart their alcohol-related problems or whatever they've decided is the metric they want to track. But also just checking in with them to let them know that you're still thinking about them and that you care. So in the course of developing harm reduction treatment for alcohol use disorders, Susan had been conducting some qualitative work with residents at the 1811 East Lake Supportive Housing Project here in Seattle. And up to about 48% of the participants in that qualitative work self-reported Native heritage, either American Indian or Alaska Native. And one of the things that they consistently said was that they wanted to see inclusion of more cultural practices, traditional practices in the programming that was available to them through the services at 1811. And by far, the most common thing when they were asked what kinds of practices did they want to see, they said talking circles. And talking circles, if you're not familiar with them, are a practice that most likely came out of the Plains tribes, but has been embraced by most Native cultures and tribal cultures in recent years. And so that was what they said that they wanted to see in the programming. And so Susan invited me, or more like twisted my arm, to get me to go to 1811 and conduct these harm reduction focused talking circles, which I got to admit, at first I did not think this was going to work. I didn't think you were even allowed to do that with a person who was intoxicated, because it's kind of considered a sacred space and a sacred practice. But we did consult with some other Native healers from the area and got their blessing, if somewhat begrudgingly, to proceed. And so we did do some pilot talking circles at 1811, and they were very well received, and really seemed to change the way people were interacting during that time. We also have developed an individual-based harm reduction treatment for American Indians and Alaska Natives that incorporates cultural practices as requested by the participant, and as able to be accommodated. So back to the talking circles. If you're not familiar with the practice, this diagram sort of lays out the basic steps to the practice. Typically the circle keeper who's facilitating the circle will provide a brief introduction to the traditions of the practice, and that being that there's a talking piece, whether that be a stone or a feather or a stick or whatever it is, that usually has some significance to the circle keeper, and that only the person who's holding that object should be speaking. And then they'll introduce the topic for the circle that day, whether it be through a story or a parable of some kind, or just a question that they pose to the group of individuals participating. And then oftentimes people will use some kind of purification practice for the space. Smudging with cedar or sage is common. And then the circle progresses with the passing of the talking piece around the circle and everyone sharing their perspective on the question or the topic or the story. And through this process, since they're the only ones talking and everyone else is listening with their hearts, people just will gradually open themselves to the others that are there and share deeper and deeper feelings and perspectives. And this will go on until it doesn't need to anymore and there's nothing that's left unsaid on the topic. And at that point, there's generally a spontaneous expression of gratitude where people just feel the need to thank the other participants for being there and for hearing their truth and for sharing with them. And this practice really did shape the behavior of the participants in ways that, you know, in the beginning, they may have come in more intoxicated and maybe a little more rambunctious and so on. But over the course of attending multiple talking circles, they may have still been intoxicated when they came in, but they were more respectful, and the tone in the room would even shift to one of even reverence and peace. So that was a pretty dramatic observation from that experiment. And so we've since written a couple of grants, one of which proposes to evaluate the effectiveness of harm reduction focused talking circles in a primary care clinic at an urban Indian health organization here in Seattle that most of you probably know the name of, Seattle Indian Health Board. And it scored very well at an NIAAA review and is very likely to be funded. So we are very likely to get to do this work, evaluating the effectiveness of this practice in the spring of 2018. So I did mention that we also had developed an individual-based intervention for American Indian and Alaska Natives with alcohol use disorders. And the components, the main components of that intervention are shown here. You know, we offer personalized alcohol feedback, support safer drinking strategies, but we incorporate patient-driven ceremonial practices. And that would be up to the client, of course, as to what they wanted to do to open and close the sessions. If they wanted to have a prayer song at the beginning with hand drumming, if they wanted to smudge the space to set the intention and the feeling in the room, then certainly we would accommodate those desires. And just, you know, they really get to call the shots and say how they want this conducted. And again, we consulted with Native healers in the area to consider different things that we might be able to offer them, and they were more than willing to share those with me and to give me permission to use those practices with these patients, which I was very honored by. And then, of course, we kept the component of eliciting harm reduction goals and the overall spirit of compassion and acceptance that Susan outlined earlier in the harm reduction heart set and mindset. This is what's referred to as a theoretical model or a logic model of what we think might be happening. And my hypothesized mechanism of action for harm reduction talking circles in particular, and potentially even the individual treatment, is this idea of native enculturation. And that's the notion that a movement for a native person, for an indigenous person, movement toward their cultural identity and their place in their community as an indigenous person with a role to play and a service to be given for their family, for their community, for their tribe, is an inherently healing experience. And that engagement in cultural activities and reconnecting with who they are to their people very likely could be responsible for the improved alcohol outcomes as well as improvements in quality of life. And through the reduced alcohol related problems, you would get reduced service use and engagement in activities that are likely to get them to need publicly funded services like emergency rooms and ambulances and jails and things like this.
So that is a little bit about harm reduction treatment and its adaptations. We want to acknowledge our staff and trainees and the community members that we've worked with and our many, many community partners. And Alan Marlatt, whose work that he was one of my mentors, really inspired a lot of our desire to infuse substance use treatment with more compassion. And we have brought together some resources on harm reduction that we highly recommend. Excellent websites. Of course, you can go to our website at the Heart Center. But also the Harm Reduction Coalition has a wonderful website at harmreduction.org that has a lot of pamphlets that you can print out for clients, that you can educate yourself about safer use. There are some really great materials also at the International Harm Reduction Association website. The hamsnetwork.org is a really great website that is user-run, and people get together online to talk about how they're using substances more safely. That can be a lot of support since there isn't a lot of available treatment resources for harm reduction right now. There's some great self-help books that we have listed here, as well as really great therapy manuals on harm reduction. Especially I'd like to recommend our colleague Pat Denning and Jeannie Little's book on practicing harm reduction psychotherapy. And if you have any questions about these slides, or if you are interested in the materials or learning more about actual clinical trainings, which we provide on a regular basis to community-based organizations, please feel free to contact Lonnie or myself. And we really appreciate you being here today and extending the hospitality to us and making harm reduction a part of your day.
Yeah. Wado, thank you very much.